Thank you so much for having me. As previously mentioned, I'm a genetic counselor. I work predominantly in cancer genetics, although I was trained in all of the spaces. And so tonight we'll be exploring genetic risks as they impact the Ashkenazi Jewish community with a focus primarily on cancer, but we'll go beyond that. And you'll see what I mean as we progress through the PowerPoint. All right, so to start, just a quick overview of what we'll accomplish this evening. We'll do a little bit of a genetics 101, just the basics of what you need to understand in order to kind of understand the genetic basis of some of these conditions. From there, we'll explore the founder effect and how this has impacted the Ashkenazi Jewish specifically. We'll discuss hereditary cancer genetics. We'll go into genetics beyond cancer, so other recessive conditions that run at higher frequencies in the Ashkenazi Jewish population. And then we'll discuss genetic testing today and where we're at in 2025. And then lastly, I'll leave you with some resources in case there is anything that resonates with you and you'd like to explore some of these options yourself. So to get started, we'll go into sort of the genetics 101. So all of us are individuals that are made up of over 20,000 genes. All of our genes are actually stored within each cell, and they're kind of bundled into what we call chromosomes. So we have 46 chromosomes housing 20 some odd thousand genes. But when you actually kind of spread these chromosomes out and read and look at the genes, they're actually just written as a code made up of 4 different letters, A, T, C, and G. And it's actually the ordering of the letters that actually creates the protein product that is actually produced in the end. And that is the building block of our body, that protein product. So you can kind of think of your genes as the instruction manual for building your body, and that protein product being the building block. Now, when there's spelling mistakes, then there's chunks missing or added to genes, or certain letters are deleted or added in, that is what we call a mutation or a pathogenic variant, specifically when it results in a change to the protein product that doesn't allow it to do its job anymore. So that's what we're looking for with genetic testing. We're reading through your genetic code and trying to see, is there any spelling mistakes? Is there any pieces missing or added that have changed the way a protein is produced, and thus we're having some sort of negative impact on the body. So when we think about our genetic information and how it's inherited, like I said, we have all of these genes that get stored into these chromosome packages, and these packages are in all of our cells present in 46. So there's 46 copies of them. Now, the sperm cells, the egg cells, these are what we call haploid cells. So they are present with only half of that genetic information with just 23 chromosomes. Now, it's variable which copy of each chromosome is actually present in the egg or the sperm, but each one of them has half, so that when the egg and the sperm come together and you form an embryo, it has now new genetic information, one from each parent, or 50% from each parent, I should say, that now form a brand new person or human. So when we're thinking about how genetic disease is inherited, we kind of get this general basic concept of half of our genetic information came from mom's side, half came from dad's, but there's different patterns within certain conditions for how that information is actually passed on or transferred down. And that all depends on, how many copies of that protein product does the body actually need to function. So the 2 main modes that we'll explore tonight, the main inheritance patterns, are autosomal dominant and autosomal recessive. These might be terms that you have heard from a biology class at one point, but these are the 2 most common inheritance patterns. Autosomal dominant, meaning it just takes one mutation in one of your 2 copies of that gene, either the one you inherited from your mom's side or your dad's, to actually have a feature of the condition. So if we're talking about inherited cancer, it's just one copy of one of these genes that needs to be mutated in order to have heightened risks of cancer. For recessive conditions, what you actually need is both copies of the gene to carry a mutation within it. So this means that you've inherited from both of your parents a mutation. Now, the parents themselves, if they only carry one mutation, they're likely unaffected because most recessive conditions don't have some sort of feature or clinical implication for the individual that just carries one mutation. So it's really important to kind of understand the distinction, because I get asked a lot about, oh, whether this can skip a generation or why haven't we seen things in a family before. And it's really these inheritance patterns that patients are getting at. So with hereditary cancer conditions, most of them are dominantly inherited, which means they do not skip a generation. They are directly passed, down from parent to child, and as long as you have one mutation, you have that condition. Whereas these recessive conditions, because you need two mutations, often they lie pretty dormant within families, and they can go generations and generations without actually having the condition present, because it does take an element of random chance of somebody who carries that mutation partnering with someone who carries a mutation within the same gene. And then even at that chance, it's only a 1 in 4 odds that both parents who carry that mutation would pass them on to a child. So it's a 1 in 4 chance of a affected child, even if both parents are carriers. And then there are other nuances to this. There are some conditions that are X-linked. There's some conditions that are maternally inherited just through mom. Not in today's lecture will we cover all of those, but what's really important to understand with autosomal dominant and recessive conditions is neither of these types of conditions are related or linked to sex. So you are equally as likely to pass on one of these mutations to a son or a daughter alike. And that will become more important as we move through. All right, so we'll talk a little bit about the founder effect and how this has impacted the Ashkenazi Jewish community, because I think it's important to understand how some communities have higher chances of certain genetic conditions. And in order to do that, we have to look at how populations form and how genes actually travel through generations. So thinking about this concept broadly of the founder effect. So this occurs when there is a new population that is established by a smaller group of individuals who have left a larger or more diverse population. And this creates a new population that has less genetic diversity just because it's based off of a smaller group of individuals. Now, the genetics of that smaller group of individuals may not be super reflective of the community that they've come from. That is just sort of the luck of the draw or the odds of who gets pulled out from that larger population to start a smaller population. So when this happens, when groups kind of migrate or found new territories or lands, we tend to see these founder mutations pop up, which means that there might be like a specific genetic mutation that someone in that group might carry. And then after years and years and years of breeding and offspring being produced, we see that same mutation being passed down through descendants. And so it's disproportionately represented within a certain population. And so it might sound a little bit hard to kind of wrap your head around. So I like to give this analogy of a mixed jar of jelly beans to kind of make it a little more tangible. So hypothetically, if we had this mixed jar of jelly beans as that representation of genetic diversity. Now, if I was to take out a small handful of the jelly beans off the top and start a new jar, then I might have a different representation of certain colors simply by random chance. So looking at this picture here, if I skimmed off the top, you'd see, 3 yellows, 2 reds, a green, and orange. There are no pink jelly beans. There are no white jelly beans. There's no purple jelly beans in my new jar. And so that means that we're not necessarily seeing that full spectrum of the genetic diversity that it came from. And now, hypothetically, if jelly beans were able to reproduce and create a full new jar in my new one, then you may see an abundance of yellow and abundance of red, because those are the predominant things that we pulled off the top, but they're not reflective of the greater community. So thinking about the Ashkenazi Jewish community, what we know is that the Ashkenazi Jewish population traces its origins back to a small group that settled in Central and Eastern Europe hundreds of years ago. And there was geographic isolation as well as a number of persecution events that have led to what we call genetic bottlenecks. So this can be, over time, populations who had been forced to shrink or reduce in size, also losing an element of that genetic diversity as a part of that process. And so while we have a population of survivors, there is decreasing genetic diversity in those who have survived and maintained this community. And then in addition to that, there is this element of a community that shares religious and cultural beliefs. And within that, there's sort of this element of continuing to extend the lineage and marry and procreate within the community, which also then doesn't introduce new genetic diversity. So over years and years and years and generations, this lack of genetic diversity, first happening based on geographic isolation and then being further exacerbated by persecution events, has now led to sort of this lack of diversity within the Ashkenazi Jewish genetics. Now, this is not something that's just specific to the Ashkenazi Jewish population. This is just a phenomenon that happens in the world based on geographic isolation and similarly, isolation of certain groups. So, for example, the Finnish population, we see a ton of this founder effect with them. They have some geographic isolation, and as a result, there are founder mutations for certain metabolic disorders that are more prevalent in that community. Similarly, French Canadian population, they are also, isolated geographically, as well as that same sort of sense of trying to maintain the language and the culture and a preference to procreate within the French Canadian community, but it has led to a lack of diversity that has led to conditions like Tay-Sachs being far more prevalent or common within the French Canadian community. We see the same thing with the West African community with BRCA1 mutations, and same thing with Amish and Mennonite communities with maple syrup urine disease and BRCA2. This is not an all-encompassing list. This is just a few examples to say founder mutations can occur in any population that has shared ancestry, that has some sort of historic or geographic isolation, and they should be not thought of as anything more than just a reflection of, history and migration and the survival of a certain group of people. It isn't something that, should be thought of as a negative thing at all. I think the nice thing about living in 2025 is that we're aware of what these mutations are and what we can do about them. So even if they run at a higher frequency, there's steps that we can take to be proactive and get ahead of them. So speaking specifically with respect to cancer, now within this presentation, I would say this is more my area of expertise, given that this is the space that I work in. So I will try not to dive too deep, but keep this more general. But you may hear this expression a lot: all cancer is genetic, but not all cancer is hereditary. What we mean when we say this is that all that cancer is your own cells that have accumulated enough DNA damage to kind of flip or turn cancerous and grow and divide without control. And when there's that uncontrolled cell division, that's when tumors form and so forth. So at its basis, they're your own cells that have your DNA that's created mutations or genetic variants that have led itself to this uncontrolled cell division. So there's a genetic component to all cancer because it depends on that DNA mutations to start that cell lineage. But that doesn't mean that all cancer is hereditary. Hereditary cancers are only a small subset of the larger group. So only 5 to 10% of the time is there an inherited mutation, meaning it's been something that you have had since birth, something you could have received from your mother or father. That's the initial mutation that may end up leading to cancer development. Now, we also kind of flag here that some cancers are familial. I would say these can be due to a various amount of things. It could be that families have shared environmental exposures. It could be that families have maybe other genetic risk factors that we can't quite quantify in the same way that we can with like a single gene mutation. So I will say, while some cancers look or appear like they run within a family, we really know only the small subset do, in a single gene kind of mutation way. And that we'll be focusing on for this presentation, this blue slice labeled hereditary cancer. So there are certain flags that you can see, to kind of signal that there is a potential inherited cause to the cancer seen within a family. So if we see cancer running in multiple generations, if we see anyone getting diagnosed with their cancers at a younger than average age, so typically anything under the age of 50 starts to raise a little bit more concern. If we see an individual in the family that's had multiple primaries, meaning cancer in different organs that's kind of arose unrelated to one another, that could also be a signal that there might be some underlying genetic basis to the cancers that we've seen. There are certain cancers that tend to be more likely to be genetic than others. For example, ovarian cancer or male breast cancer. So for that reason, these types of features within a family history are something that automatically kind of triggers our senses to say this is somebody that we need to test. But then there's also this extra risk factor of ancestry. So if we know that this person is of an ancestry that has a higher carrier frequency of certain gene mutations, and there's family history of certain kinds of cancers, these could be things that flag someone for a referral over to a genetics group. So thinking about some cancers being more likely to be hereditary than others, I kind of pulled a few examples on the slide just to show you how this works. So colon cancer, for example, is a really common cancer. Minority of the time it's genetic or hereditary. Only 5% of cases tend to be due to some sort of inherited gene mutation. Breast cancer, on the other hand, it's about 5 to 10% of the time. Pancreatic cancer, closer to that 10%. But ovarian cancer, like I previously mentioned, it can be as high as 1 in 5 cases being due to a single gene mutation that's inherited through a family. So that always kind of prompts us to take a deeper dive and look at the genetics. On the flip side, there are some cancers that are almost never genetic. So lung cancers, for example, we rarely find anything genetic. More often, even if it is running in a family, it's due to some type of shared environmental exposure or things like tobacco use being more prevalent within a certain family. Same thing with cervical cancer. Most often, it's actually related to HPV viral exposures. Not frequently is this actually genetic. And then same thing with basal cell carcinomas. These can be brought about by just increased sun exposure. They're almost never hereditary. There's rare exceptions that are. But so when you're thinking of your family history and you're saying, okay, there's an abundance of cancer here, something must be going on, it's really important to think about what cancer types are being seen. And that's something that a genetic counselor can help walk you through. And I do feel like a decent amount of my patients end up feeling pretty reassured when we kind of break it down through this lens of, well, this type of cancer is not typically genetic, and nor is this, and these two are not related to one another by this reason. It kind of gives a little bit more peace of mind that while these hereditary cancer syndromes seem big and scary, they have very specific pictures that they paint. And so not all cancers in a family are, as worrisome as others. So a little bit of a deeper dive into BRCA1 and BRCA2. So these are genes that likely all of us have heard of before. They're genes that we all carry, and we have 2 copies of each one of them. One we inherited from our mom, one from our dad. And these genes basically create proteins that help to repair DNA damage within cells. So as I was speaking about cancer genesis before, and you kind of think of it as an accumulation of DNA errors or mistakes that eventually lead to the cells growing and dividing and forming tumors, BRCA1 and 2 have a critical role in kind of stopping that process from happening. And that's why individuals who inherit a mutation in their BRCA1 or 2 copy are less able to repair cells that have damage and thus more likely to have certain risks of certain cancers. Now, something to note about BRCA1 and 2 is that these are dominantly inherited genes, meaning it just takes one mutation in one of the 2 copies of one of these genes, to have that heightened risk of cancer. That also means that these are equally as likely to be passed on to children by either men or women. I hear this a ton where mothers feel like they were only going to pass on this mutation to their daughter, but it's actually equally as likely with every pregnancy. I also hear from patients, well, this is on my dad's side, so it won't come down to me. That is not the case either. So this is equally as heritable to men and women. So why is BRCA 1 and 2 often talked about in relation to the Ashkenazi Jewish community? That is because there are 3 founder mutations that I've listed on the slide here. And these founder mutations have been traced back to that kind of Central Eastern European group. And over time, because of the founder effect and the bottlenecks that we spoke about, they have become more and more prevalent. So the carrier frequency is thought to be about 1 in 40, meaning 1 in 40 individuals of Ashkenazi Jewish ancestry carries a BRCA1 or 2 mutation. Now, this is about 5 times more likely than the general population of carrying a BRCA1 or 2 mutation. The average person in the general population might have somewhere between a 1 in 200 to 1 in 300 chance of being a carrier. So what this means is that if you have family history of breast, ovarian, prostate cancer, pancreatic cancer, and have Ashkenazi Jewish ancestry, then this could actually be the BRCA1 or 2 mutation actually making itself known within your family. And so for individuals who are Ashkenazi Jewish and also have breast, ovarian, prostate, or pancreatic cancer in the family, we strongly encourage genetic testing regardless of the age of diagnosis of the individuals who have had the cancer. And then for those who don't have family history but are still curious about knowing their BRCA status, you could still certainly consider genetic evaluation, and current guidelines definitely support testing just based on ancestry because of that 1 in 40 chance of being a carrier. So with respect to BRCA1 and 2, I'll kind of keep this high level, but the main cancers that we can see with a BRCA1 or 2 mutation is breast cancer, pancreatic cancer, ovarian, and prostate. So breast cancer, we see increased risks for both men and women. Female breast cancer risks can be as high as 75% lifetime risk. Male breast cancer risk around 8% lifetime risk. Pancreatic cancer risk can be as high as 5 to 10%, more so seen with BRCA2 than with BRCA1. Ovarian cancer can be up to a 50% lifetime risk with BRCA1, more in the neighborhood of 30% with BRCA2. And then prostate cancer can be up to 30%, although some studies have quoted as high as 40 or 60%, depending on the data you're looking at. More often, we see that high-grade prostate cancers that are more likely to metastasize. And so it is also important to kind of know status to kind of understand or predict what type of cancers we might see even within this spectrum. I also want to point out that all of these risks are applicable if you have one mutation in a BRCA1 or 2 gene. Now, if you inherited a copy of both genes mutated of either BRCA1 or BRCA2, meaning both of your parents were carriers, this would actually potentially cause a different condition that is a pediatric onset cancer condition called Fanconi anemia. And so there is a recessive risk with these 2 genes, which is why we always encourage, if you are a carrier and you're actively family planning, trying to get your partner tested for BRCA1 or 2 or whatever you carry in order to make sure that there isn't a potential different risk to offspring. Now, I won't go into this too much, but BRCA management changes can be made for men and women. And so this kind of answers the question of, why know my status? What do I do with this information? Well, the main goal once we learn of a BRCA mutation is, now that we have found this higher risk of cancer, how can we take steps to catch cancers early or prevent them altogether? For BRCA related breast cancer risks, you can either go down the avenue of early detection by using a protocol that involves a breast MRI and a mammogram, alternating those every 6 months. Typically, this type of surveillance begins at age 25, and then with just the MRI, and then at 30, adding in the mammogram. Alternatively, you can explore a surgical option aimed more at prevention. That would be something like a preventative double mastectomy, reducing as much breast tissue as possible to take away sort of that origin site for the cancer, and that would dramatically reduce risk of the breast cancer overall. Same applies to ovaries. Unfortunately, we don't have great means of screening for ovarian cancer, but we do know that a preventative oophorectomy is a highly effective way of reducing your risk of ovarian cancer. And so the time frame for that surgery is pretty variable, but at the earliest would be recommended for a BRCA1 carrier at 35 years old, at the latest for a BRCA2 carrier at 45 years old. So somewhere in that window, discussions about this type of surgery would happen. And then for any man or woman for that matter who carries a BRCA mutation, we do have pancreatic cancer screening protocols. We do this at Penn through an endoscopic ultrasound or an MRI that looks at the pancreas once per year. We usually recommend alternating between the two types of imaging. So every other year, you're getting the same type. And this would only begin after age 50 for a BRCA carrier. For men with these mutations, it is still really important to learn your status because there is male breast cancer risk, and this is something that is not often screened for or paid attention to because the general population risk of male breast cancer is pretty low. But men who have BRCA mutations are encouraged to start screening with an annual physical, or even every 6 months having a chest wall exam. And then self breast exams are highly encouraged as well. And then if there is enough breast tissue, there can be consideration of mammograms to look at the breast tissue as well. For prostate cancer risk, screening begins at age 40 through the blood test known as a PSA, as well as digital rectal exams. This is something that many might think, well, I get prostate screening anyway, but the reason I really do stress to families that have these mutations that they're important to learn about is because there's sort of a general movement away from prostate cancer screening for the general population. There's this thought that we are over screening for prostate cancer, which most of the time is not really aggressive, is pretty slow growing. And so we're finding too many of these like low risk prostate cancers. And so maybe we should dial back our screening. We do not want men with BRCA mutations to fall into that general population ideology. We really want to kind of make sure we're staying on the prostate screening for men with these mutations because they tend to have a higher risk or more aggressive type of prostate cancer when it does present. And then the same pancreatic cancer protocol would apply to men who carry BRCA mutations as well. So in terms of how to do hereditary cancer genetic testing, this is something that's evolved immensely over the last 25 years. I would say in the early days, in the late 90s, early 2000s, we were really only looking for these 3 Ashkenazi Jewish founder mutations. And that's because it was through the help of looking at families of Ashkenazi Jewish ancestry with breast and ovarian cancer clustered throughout that we even were able to isolate these genes and find these spots that we recognized were linked with the cancers we were seeing. So in the earliest iterations, that's all we could test for. And then as the technology evolved and we got the ability to actually fully sequence the genes, that became more of the norm, but we would only look at single syndromes or single genes. We wouldn't be testing multiple things at the same time. We would really just say, we think this is BRCA, let's just look at BRCA1 and 2. Now we're in the age of multi-gene panel testing, and we've been here for about 10 years or so, maybe actually almost 12. And so multi-gene panel testing, it really changed the way we thought about how to approach genetic diagnosis because we were all of a sudden able to sequence multiple genes in parallel at the same time, which meant that we could, for a lower cost, get more information back. So now, very rarely do I actually order sort of a single syndrome test that's just looking at one focused gene, unless there's something that's absolutely known already in the family. More often, patients are going for this multi-gene panel where they can kind of cast a wider net and see what comes back. And while we might be most suspicious of a BRCA mutation, we can include lower risk or more moderate risk breast genes and ovarian genes that might give us a similar family picture. So we're more likely to capture what's happening. We have higher diagnostic yield. It's also, more cost effective to do testing this way. That said, this introduces more uncertainty. So you can have newer genes that are not well understood on these panels. You can have mutations within a gene that are more moderate in risk or lower penetrance, in which case we don't really have clear understanding of how we should manage these mutations on the back end. And then sometimes there's not necessarily a clear medical management guideline in place of what to do for this type of mutation in the same way that we have that for BRCA1 and 2. So all of this to say, there are a variety of options out there, and speaking with a genetics professional like a genetic counselor would help you get a good grasp of what are your options and what are the pros and cons of each. So I'd highly recommend speaking to a genetic counselor before pursuing any genetic testing yourself. Now, I kind of brought up these multi-gene panel tests because before, when we were just looking at the Ashkenazi Jewish founder mutations or just looking at BRCA1 and 2, we would kind of find ourselves in this yes or no, you have it or you don't scenario. And now what we're finding is when we do these multi-gene panel tests, we end up pulling in other founder mutations that run at decently high rates in the Ashkenazi Jewish community. So the couple I've highlighted here, the first one is in a gene called APC. Now, if you were to take to Google and look up APC, it would tell you that it causes a familial adenomatous polyposis syndrome, which is a fancy way of saying it causes a large amount of colon polyps, hundreds, in fact, so much so that it's really hard to keep up with the polyp burden. In many instances, we actually recommend preventative removal of the colon in order to keep up with the volume of polyps. Now, the reason I go into all of this detail is to say this specific founder mutation, the one that's carried in the Ashkenazi Jewish community, I1307K, is not causal of familial adenomatous polyposis syndrome. It does not cause that hundreds of colon polyps. It does not need a preventative surgery that drastic. We do know it has a slight link to colon cancer. It seems to cause up to about a 10% chance of colon cancer compared to the general population's 5% lifetime risk of colon cancer. It's a jump. So in that scenario, we're usually recommending cutting the colonoscopy interval in half. The general population goes once every 10 years. Individuals who have this mutation should go every 5, but it's far less severe and drastic than what other mutations in this gene would give you. Similarly, CHEK2, which is often included on any kind of breast cancer panel, it is a pretty common breast cancer risk gene. It has 2 founder mutations within it that have been traced back to Eastern European, Central European, Ashkenazi Jewish ancestry groups. So I157T and S428F are the names of these 2 variants. Basically, these 2 variants we know are really low penetrance, meaning they don't really tend to show up as frequently with the volume of cancers that you might see with a traditional truncating CHEK2 mutation. In fact, when you actually look at the data, the risk of developing breast cancer for someone who carries one of these 2 mutations is really just slightly higher than the general population risk, which is about 13%. And so for that reason, there really aren't any recommendations to pursue additional breast screening. It doesn't seem to be appropriate based on the level of risk that these 2 pose. So it's more of just a little risk factor. It's not in the same realm as like a BRCA1 or 2 mutation, but we pull these in pretty frequently when we are doing genetic testing, especially through a larger panel. So I flag this because when you're making the decision of what kind of testing to do, knowing that these could potentially pop up for you is a good piece of information to help you kind of guide how would I think or feel if I got one of these mutations back and I was told we're not going to do anything differently to manage it. Would that be something that caused me distress, or is this something I'm comfortable knowing? And so these are the types of things to ask yourself while you're going through the process of getting testing. And then I'm flagging another Ashkenazi Jewish founder mutation within a cancer risk gene, just to highlight that sometimes they're not very common. And while they're rare, they're higher risk. So TP53 in general is a pretty rare cancer syndrome. It causes Li-Fraumeni syndrome. It is not something that we see nearly as often as like a BRCA1 or 2 mutation. And it does have high degrees of cancer, more often earlier onset in life. So most people present in their 20s and 30s, if not with a pediatric onset cancer. We tend to see a broader spectrum of cancers. So we can see anything from breast cancer to brain cancers, sarcomas, adrenal cortical carcinomas, blood cancers, to name a few. With this specific Ashkenazi Jewish founder, it's a little bit what we call hypomorphic. It's thought to be a little bit less risky than some of the other mutations within this gene, but you can still see that same full spectrum of cancers, a little less likely to see the sarcomas. You can see similar incidents of the pediatric onset adrenal cortical carcinomas, but what they tend to see is more often a little bit later, these cancers setting in, past the 20s and 30s, a little bit later in life. Now, for anyone who carries this kind of mutation, the recommendation is screening through a whole body MRI annually, as well as a brain MRI annually. But this is a very rare mutation. So even though it's a founder, it's something that has popped up, it has not popped up in an abundance of families. It's really seen in very few Ashkenazi Jewish families. So in terms of the broader takeaways, BRCA1 and 2 Ashkenazi Jewish founder mutations are common. That's that 1 in 40 chance of being a carrier. And so for that reason, testing can be considered for anyone of Ashkenazi Jewish descent, though we highly recommend it for anyone who has breast, ovarian, prostate, and pancreatic cancer in the family as well. And then testing beyond BRCA1 and 2 is commonly offered as part of your genetic services. So this multi-gene panel testing is an option that you'll be presented with, largely because it's the same cost to patients, it's the same turnaround time, it's the same amount of sample that you need. So you get more output for the same input. But there are pros and cons to panel genetic testing, and so I highly recommend speaking with a genetic counselor in order to decide what's right for you. And being aware that there's other founder mutations out there that are less risky, but could still pose some sort of increased risk to you, like the CHEK2 ones, like the APC one, that you could also be tested for at the same time as BRCA1 and 2. All right, so now we'll switch directions and we'll go into beyond cancer, what other genetic risks exist for the Ashkenazi Jewish community. One to think about is just generally speaking, or thinking back to that earlier slide I had about those recessive conditions. This is kind of where we'll explore that. So recessive conditions, as a reminder, are conditions that only appear if you inherit 2 mutations, meaning one from your mom, one from your dad, in the same gene. These type of recessive conditions can actually kind of mask themselves because usually individuals who carry just one mutation don't have any other features that are indicating that there's this condition lying dormant. So it can be multiple generations until somebody actually encounters and mates or procreates with someone who carries the same mutation, and then all of a sudden you see this condition appear within a family. Now, the type of testing that gets at this type of risk is what we call carrier screening. This is usually used to identify couples that are at risk for having a child with a specific type of condition. The purpose of this testing is not to diagnose a parent with a disorder. So, and this is really where I want to distinguish it, because this happens all the time in clinic. I have a lot of patients who will say, oh, my sister must have had BRCA testing because she had like 200 genes looked at before she got pregnant. That is 2 different distinct types of tests. BRCA1 and 2 will never be on, well, at least are not presently on any carrier screening panels. And I've been doing this kind of deep dive in this space for a while to almost try to find a way to merge the 2 tests. But right now, the tests are very siloed. So the chances are, if you have a relative, a sibling, or you yourself have had one of these 200 plus gene carrier screens, and you assume that you've been tested for BRCA as a result, you likely have not been. And you should go back to your report and look at the gene list, and you more often than not will not see BRCA1 or 2 on there. So that could indicate that you actually need to pursue additional testing to what you've had looked at. Because again, the purpose is to diagnose disorders that would appear suddenly in the child, not something that would impact the parent. And that's why they've kind of separated carrier screening from cancer genetic testing at this point in time. Now, carrier screening can kind of be done in two different ways. Sometimes it's offered preconception, meaning that someone is interested in family planning, and one partner is then tested for a multitude of conditions. And if they come back positive for one of these recessive conditions, then their partner is tested for that same condition in a more targeted fashion. Although the partner can opt for a more comprehensive test, the idea is that we're all carriers of something. It's just unlikely that you and your partner are carrying the exact same a mutation within the exact same gene. And so that's kind of the whole premise, is if you at least rule out that there is no overlap in terms of what kinds of mutations you carry, then it can give some more peace of mind with the pregnancy ahead. Now, if both parents actually are carriers of the same condition, then it's still that 1 in 4 chance, that 25% chance that both parents would actually pass on the mutation to the child at the same time. That said, if you discover that you and your partner are both carriers of the same condition, then this opens up a lot of options. One being discussions of pre-implantation genetic testing, so testing embryos to see if they are affected with the condition before you implant them. You can also consider things like adoption or using donor sperm or eggs in order to try to circumvent passing on the condition. Or many couples conceive naturally and then rely more on methods to test the pregnancy to see if that 25% chance of the pregnancy being affected has actually come to be. So we'll explore that in a moment. So with individuals who are offered carrier screening during pregnancy, the process is a little bit more truncated because we don't have as much time on our hands. So usually in that scenario, both partners are simultaneously tested for, these hundreds of gene lists. And then if both are carriers of the same condition, then the discussions move towards prenatal testing, which is done more in an invasive way through something like a amniocentesis, CVS, for example, something where we can kind of sample a proxy of the baby's DNA in order to see if they actually carry that condition or not. So the American College of Obstetrics and Gynecology has previously recommended carrier screening for anyone interested in family planning or having a pregnancy. The historic way to recommend carrier screening, or I guess their historic guidelines have focused more on ancestry-based or ethnicity-based screening. So recommending, for certain populations of people to get tested for certain conditions that run at higher frequencies within them. So within Ashkenazi Jewish communities, they recommended Canavan's disease get looked at, cystic fibrosis, familial dysautonomia, and Tay-Sachs disease. And that is because there is estimated to be between a 1 in 4 and 1 in 5 chance, if you're Ashkenazi Jewish, of carrying one of these 4 conditions. So it's a pretty high yield just based on the prevalence of these conditions. But now that genetic testing has kind of changed in how we perform it and what it costs to do it, more recently, expert panels are kind of advocating for a more comprehensive approach, not so much saying siloed in ethnicity-based or ancestry-based screening. So there are a number of other genetic conditions with high carrier frequencies in the Ashkenazi Jewish population. We'll go into a couple of them today, but this is not an all-encompassing list. This is just, sort of a list recommended by ACMG to be tested for in the event that you are Ashkenazi Jewish. So the first one to think about is Tay-Sachs disease. Tay-Sachs you may have heard of because this is a relatively common condition. It's carried by 1 in 30 individuals of Ashkenazi Jewish ancestry. This is a pretty severe pediatric onset recessive condition. So if both parents are carriers and that 25% chance happens and the child is affected, you typically see sort of a progressive weakness, loss of motor skills, decreased visual attention, and sort of this developmental plateau around 8 to 10 months of age. And so while it's difficult to kind of diagnose in early childhood. Now newborn screening includes sort of this HEX enzyme activity test to be able to kind of pick it up in earlier childhood. And then, like I said, it typically is pretty apparent or presents by 8 to 10 months. There are two common founder mutations that are specific to the Ashkenazi Jewish population, which is why it's more prevalent in the same sort of way that the BRCA1 and 2 mutations are. But there's founder mutations that exist within other populations. So French Canadians have a higher risk of Tay-Sachs, as well as Cajuns from Louisiana, because there are other founder mutations. All right, and then Gaucher's disease is another one that is carried pretty commonly. It's about a 1 in 18 chance if you're Ashkenazi Jewish of carrying a Gaucher disease variant, and it's a mutation in the gene called GBA. Now, this condition is characterized by the buildup of fat in tissues that leads to damage or dysfunction of specific organs and tissues. The founder mutations that we tend to see, it's one specific one that's carried by majority of individuals with Ashkenazi Jewish ancestry. And what's important to note is that if you inherit two, so both of your parents carrying the same Ashkenazi Jewish founder mutation, it seems to have a more mild presentation of the actual disease. So it could be a little bit more hypomorphic, if you will. There are other founder mutation groups, so Spanish, Portuguese, Swedish, Greek. There's a number of populations that also carry a disproportionate volume of GBA mutations as well. Now, this I highlight as well because it's one of the only recessive conditions that we will talk about tonight that has actually an impact in the carrier state, meaning to the parent who has just one copy mutated, there is actually a link between mutations in GBA and late onset Parkinson's disease. Now, we know that late onset Parkinson's disease is multifactorial, meaning it has some sort of contribution from environment and lifestyle and age, but genetics can play a role. And so what we've seen is that if you carry a mutation in GBA in one of your copies of the gene, it's like twice as likely by age 60 to have Parkinson's, and then, threefold by age 80. And so this is just something to think about is as you're doing these carrier screens, there is the potential that you learn something that might impact your health or the way that you perceive your health, even though the main goal is to explore conditions that would impact a pregnancy, because a few of these conditions have something that would actually impact in the heterozygous state or in the single mutation state an adult. Canavan's disease, in the interest of time, I won't get too deep into, but another condition that is disproportionately carried in the Ashkenazi Jewish community, thanks to two specific common founder mutations. The rate of carriers is about 1 in 42 to 1 in 82. And then familial dysautonomia, also another one that falls in this same vein. This is a condition that mainly impacts the autonomic and sensory nervous system, and it can have a multitude of presentations, but it's specifically one founder mutation that accounts for like 99% of those who are Ashkenazi Jewish who carry familial dysautonomia. And then cystic fibrosis, I want to spend a little bit more time here because this is likely a condition you've heard of before. It's a condition that causes a thick, sticky mucus to kind of build up in various organs, primarily the lungs, sometimes the pancreas, the digestive tract, and it is caused by mutations in CFTR. The reason I bring it up is because this is a common condition in both Ashkenazi Jewish populations and the general population alike. So the odds of being a carrier are 1 in 24 if you are Ashkenazi Jewish, 1 in 25 for the general population. So this means that even if your partner that you're planning a pregnancy with is not Ashkenazi Jewish, there is still a pretty high likelihood that both partners could be carriers. And so for that reason, ACOG recommends carrier screening to include cystic fibrosis for any individual of any ancestry. And that sort of used to be the floor or the baseline thing that we'd want to screen for in advance of pregnancy. Okay, so we'll touch on genetic testing today. So as I lightly touched on before, we've moved away from this kind of three common Ashkenazi Jewish founder mutation testing in BRCA 1 and 2, which is where we began in the late 90s, early 2000s. Now we're in the dawn of multi-gene panel tests, things that can tell you your risks of hereditary breast and gynecologic and GI cancer risks and prostate cancer risks all in one swoop by looking at a multitude of genes. We can not only analyze your DNA, but we can also analyze the RNA now, which I will say doesn't increase diagnostic yield a ton, but there are some mutations that could be missed in your DNA that can be picked up in the RNA. Testing right now is more affordable than ever. Labs offer a self-pay option of about $250. They have patient assistance programs. That said, if you have Ashkenazi Jewish ancestry and any type of breast, ovarian, prostate, pancreatic cancer in the family, then there's a good possibility that your insurance company will actually cover the testing for you. We're able to get a lot more coverage in this space than we could 10 years ago. If you've had testing before and you had testing prior to like 2013, it also could be a good time to revisit testing for you because you likely only had BRCA 1 and 2 offered to you at that time, that kind of pre-multi-gene panel era. And now we can do a lot more for you. So if you have suspicious family history, I think it's always helpful to come back to genetics. For preconception genetic testing, like I mentioned, this was historically based on ancestry, and now there's sort of this greater appreciation that we live in a time where there's a very admixed population, and not often are your patients, one specific type of ancestry. And so we've moved towards expanded carrier screening panels that cover hundreds of conditions that are relatively common in the general population. Idea being, if we can kind of sweep through these in both partners, it can give a better sense of or a better peace of mind regarding the odds of having an affected pregnancy. It also then opens up the possibility of exploring other options for you knew that there was genetic risks that of having an affected pregnancy, or as high as 50% of having an affected pregnancy. You could explore something like pre-implantation genetic testing, testing the embryo for the genetic condition that runs through the family in order to selectively implant embryos that don't carry it. So there are options available, and just having this information in advance of a pregnancy opens up more doors for what you can explore. This slide here is just a quick glimpse of who are kind of the major labs that are doing genetic testing in this day and age. These are all clinical laboratories that offer either cancer testing or carrier screening. Some of them offer both, like Myriad and Natera. Chances are, if you've had any genetic testing, it might have been at one of these places. You also may note, and I got a question about this earlier, that 23andMe is not on here. 23andMe is not considered like a clinical laboratory, and the technology that they use is a little bit different. And so if you do get like BRCA testing, for example, through 23andMe, I would be weary of it because it's not doing a full read through of the BRCA 1 and 2 genes and checking for chunks missing and added the same way that we would do it clinically. They're looking for, I believe it's now 44 common mutations within the gene. So it's just looking at, a small portion of the gene to pick up things that are common and relevant. Now, the Ashkenazi Jewish founder mutations, they are good at picking up, but we still typically recommend getting another form or backup testing at a clinically approved laboratory, even if you've been tested through 23andMe, just to confirm that what you found is real. I would recommend, if you want to do testing, like I said, talk to a genetic counselor, because there's so many options out there, and they will be the perfect person to kind of guide you through this whole process. They'll gather your relevant personal history, your family history, give you a sense of what you actually should look into or explore based on all of that. And then in terms of navigating other like ethical or emotional considerations, they are trained to do it all. So it is a good first step, and they're also going to be the people that are able to connect you with medical providers afterwards that have expertise or understand how to manage somebody who carries one of these mutations, which is equally as important as finding the mutation. Now, one big consideration for genetic testing is genetic discrimination. So there is a federal law in place called GINA, the Genetic Information Non-Discrimination Act, that is there to protect you from having health insurance companies or employers use genetic test results against you. So they can't use them to change your premiums, treat them like a pre-existing condition or anything like that. That said, life insurance, long-term care insurance, and disability insurance are not regulated under that act. So if you wanted life insurance, long-term care, disability insurance, these types of policies, they may ask you about whether you've had genetic testing and what the results may have been. And so for that reason, I usually encourage patients, if you want those types of insurance, again, life, long-term care, or disability, take that out before you proceed with genetic testing. That way you've minimized the opportunity for some genetic discrimination to occur. All right, and then I'll leave you with some resources here. I'll leave this slide up. You can screenshot it. If you're looking to do any type of genetic testing, whether that is in the reproductive realm, in the cancer realm, I have some resources here. The Vassar Center, we're located at Penn, and we do a whole hereditary cancer program, so we can do any kind of BRCA testing or things along those lines. So you can find us through our website there. Penn also has a great reproductive genetics program. So if you're interested in carrier screening, you can also call that. And then if you want to pass this on to relatives who live further away, I've kind of put some resources that are a little bit more broad around the country. Like I said, finding a genetic counselor is really key. So if you go to the nsgc.org website, that's the National Society of Genetic Counseling's website, they have a Find a Genetic Counselor tool on their homepage. So what you have to do is just put in your zip code and the specialty that you're interested in, and they'll be able to connect you with somebody that is in your area doing the type of testing that you're looking for.